Welcome back to the second part of today's event, where we're going to speak about minimizing the risk of infection and reprocessing. We're going to have two speakers who will be addressing this topic. We have one of them online and one will join us here in the studio. The second speaker today is Ulrike Beilenhoff, who is ESGINA's scientific secretary, and she's also the GIA chairwoman, which is the German Society for Endoscopy Professionals. She's based in Ulm, Germany, and as mentioned, she'll be joining us online. Ms. Beilenhoff will speak about the importance of training, the ESGINA training curriculum, and her wish that manufacturers train all hospital staff. But that will be after we hear from Professor Bruno, who works at the Gastroenterology and Hepatology Department at the Erasmus University in Rotterdam, the Netherlands. And Professor Bruno will talk about the importance of cleaning from a technical point of view, the role of automation, and how to test efficacy of pre-cleaning. Professor Bruno, I wish you a great presentation.
Thank you, Mr. Chairman, for the kind introduction. In the upcoming 50 minutes, I hope to convince you that the issue of scope contamination and patient-to-patient infection for certain endoscopes and certain patient categories is real, and that we have a responsibility as treating physicians to contain that, and particularly the key role is there for manual cleaning of scopes. These are my disclosures. And if we talk about endoscope contamination and patient infections, we have to distinguish between endogenous infections and exogenous infections. Endogenous infections are inherent to an endoscopy procedure, and that constitutes translocation of a patient's own flora. And by essence, that's not containable by better cleaning scopes or, for example, using a single-use endoscope. However, exogenous infections are contaminated scopes that bring over a bacterial infection from the previous patient to the next patient in whom that scope is used. It's important in this discussion to also understand the difference between multi-drug resistant organisms, which are nowadays very difficult to treat because they are resistant to many antibiotics, and what we call sensitive microorganisms, in particular because the prevalence incidence of the NDRO infections are increasing. If we talk about contamination, we often talk about breaches in reprocessing, and that's very true. We know these cases where there were breaches of reprocessing and there were documented patient infections. But there are also reports where it seems that there were no breaches in reprocessing and where still patients were infected. And in all probability, that has to do with some of the complex designs of certain scopes, including duodenoscopes, ERCP scopes, and US scopes, in particular because of their mechanisms, the multiple channels, and the elevator. In the Netherlands, a few years ago, we made an effort to culture every single ERCP and US scope in the country. And we were quite successful because in the end, we had about more than 80% of all the scopes used in the Netherlands, ERCP, US scopes, that we could culture. And to our surprise, 13% of these endoscopes were contaminated with an oral or a GI bacteria. And that was independent of the brand of the endoscope or the type of the endoscope. So 13% of the scopes that were hanging ready for use in the dry cabinets contain bacteria still present from previous procedures from previous patients. Now, should that be considered a problem? Well, I think obviously. We don't want to harm patients. And now if you look in the literature, there are multiple documented duodenoscope-related outbreaks involving in particular MDOs microorganisms because they are more easily to detect as a cluster outbreak as opposed to sensitive microorganisms with many patient infections and multiple deaths. And also endoscope infections, they prolong hospital admission and associated costs. And importantly, of course, they are treated with broad-spectrum antibiotics, and that contributes to multi-drug resistance. And just as pollution is an issue with regard to humanity, the issue of the ever-increasing problem of resistance of antibiotics for certain bacteria is also an ever-increasing issue in the world. And if you look at this publication published a few years ago, looking into the problem and the burden of infections of these multi-drug resistant organisms, you can see that it differs greatly by country, by the way. There's a distinction between the north and the south of Europe, but there are over 670,000 patients that are admitted in hospital with an MDRO infection in Europe every year, amongst which, of course, patients that have an infection because of scope. And there are more than, 30,000 deaths. So it's really an increasing and important issue that we have to take into account and have to take responsibility. Now, why is this an issue, and why is a scope prone to not being clean, and why do we have 13% of scopes being contaminated with GI bacteria? Well, that has to do with the process of scope reprocessing. If you pull a scope out of a patient, you have a 8 to log 10 contamination rate with bacteria. If you then go through the process of bedside flushing and manual cleaning, you kind of halve that by 4 to 6 log 10, and then the scope goes into the high-level disinfection, and there's another decrease of this scope of these bacteria after reduction. And if you add all this up, the safety margin of this whole process is only 0 to 2 log 10. Now, that might not seem something that is of relevance or you can really relate to an issue, but if I tell you that sterilization means a safety factor of 17 log 10, you can easily understand that that small margin of safety is vulnerable. And if you have a breach in your reprocessing anywhere in the cycle, but in particular in the manual pre-cleaning, you will never be able to make up and let the high-level disinfection clean the scope. Now, another study that we did in the Netherlands some time ago was to look at the predilection sites of these contamination potential for infection. And that turned out to be, in particular, 2 sites. The forceps elevator, which already has been alluded to in previous talks, which has been addressed by the industry to make us disposable tips of the endoscope together with disposable elevators, but in particular also the suction channel and the biopsy channels are a source for contamination and in all probability biofilm formation. Now, what are the measures that we can apply to prevent infectious outbreaks with the duodenoscope? Well, first and foremost, cleaning and reprocessing according to the manufacturer's instructions. Very important, and we have to realize this is complex because the total cleaning of a scope takes more than 100 steps to go through, so it means it's vulnerable. But you have to adhere to the instructions of the manufacturer. I want to emphasize this very high manual pre-cleaning efficacy remains crucial because if you don't manual pre-clean the device adequately enough, the high-level disinfection will not make up for that. Process control, including microbiological testing, so once every month to culture your scope to kind of detect if there's an ongoing contamination of that scope. And of course, we have to look for development of novel technologies to improve the efficacy of manual pre-cleaning and also alternative ways to improve high-level disinfection, reprocessing. And there is already many things have been done, new generation of scopes, less complex tip design, disposable caps. I think what's very important, disposable working channel is a very interesting concept. And of course, what we already have been discussing, single-use scopes. Now, what would be a strategy to try to control this cycle of reprocessing is to test the efficacy of the manual pre-cleaning. And that, in potential, could be done with what we call the ATP test to look for biologic residue in the scope. And that's what we sought out to research in our center. We did a big study in more than 900 procedures where we did both ATP tests and various cultures, various scopes that we used, a total of 26 scopes and over 3,000 cultures. So after the manual cleaning, we took ATP tests on swab samples from detachable caps and the forceps elevator, and we took flushes samples of all the working channels. These results were then compared to the growth of any microorganism that we acquired in the automatic HLD, and the ATP test was considered positive when above 200 RLU. Unfortunately, if you look at this slide and this graph of ROC curves, you can readily see that the diagnostic performance of the ATP test to reliably tell whether the manual pre-cleaning process was adequate enough to ensure optimal hygiene after the HLD was simply not there. An ATP test after manual cleaning does not predict whether endoscopes will be contaminated with viable microorganisms post-HLD. There's another very intriguing avenue to take, and that is what we would call automated pre-cleaning of endoscopes, of reusable endoscopes. And that has some potential advantages. For one, that process is measurable, and of course, because it's measurable, you can better control it. It is a way of standardization of a process, which currently, because it's done by so many different people, and I told you there's so many steps to take, it's highly variable. Because it's measurable, it's traceable, and in some instances, and I will tell you later, it's environmentally more sustainable. This is a publication, very recent. It's online ahead of print. This is a study, a single-center perspective randomized controlled study, where they compared the conventional manual cleaning with the cleaning by an automated device that pulled brushes through the endoscope channels motorized and had a whole documentation system. And I did sampling and culturing after high-level disinfection and drying in over 400 cycles and measurements. And the primary endpoint was the proportion of endoscopes with a positive culture. And the outcome is intriguing. Importantly to note, it doesn't bring the culture rate down to 0, but in my opinion, there is a clinically relevant decrease of positive cultures from 23 to 15%. So that means that an automated flexible endoscope channel brushing system shows promise in the reduction of bioburden and improving scope reprocessing. There's another interesting advancement of this type of automated cleaning, which is the Aqua Typhoon, which has the advantage that it is not using any brushes. So there is no waste with regard to brushes. And also the pre-cleaning process only contains water and air without the need for consumables of chemistry. And this turbulent flow of water and air then is cleaning the working channels of the scope. This needs to be proven with scientific material, but it is a very interesting advancement of trying to control the manual pre-cleaning of endoscopes. So to come to a conclusion, the key role of manual cleaning, endoscope contamination and cross-patient infections are real for certain patients, and certain scopes are underestimated and cause burden, and we need to address this issue. Thorough manual pre-cleaning is essential for successful decontamination of the endoscope, and the manual pre-cleaning already starts in the endosuite. After you pull out the scope in the patient, you have to rinse the scope immediately to prevent the formation of biofilm. Follow the manufacturer's instructions for cleaning and use of proper materials, and novel solutions offering automated pre-cleaning of endoscopes are now available and have the potential to reduce bioburden and improve the outcome of scope reprocessing. Thank you.
Thank you for that, Professor Bruno, and please be so kind to join us here at the table. And to all the viewers, thank you for the questions that we had for the first section. Please feel free to add the questions that you have for Professor Bruno or Ms. Beilenhoff, who is going to talk us through the importance of training. Ms. Beilenhoff, the floor is all yours.
Yeah, thank you very much. Yeah, thank you very much for the invitation. I will go through the importance of training, and there are my potential conflicts of interest. I will raise different topics around training, and Marco already mentioned the construction of endoscopes. They are difficult to clean and disinfect, and they're easy to damage. And the endoscope reprocessing is really a complex procedure with a lot of factors which influence each other. And since the early 1970s, what we already heard, there were reports about endoscopy-associated infections. And you see here different reasons why this happened. And there is, of course, a non-compliance with guidelines and manufacturers' recommendations, but also taking the wrong equipment and also technical problems with the design, limitations with damages of endoscopes, and with the failure of washer disinfectors. And we already heard that we had the infections and outbreaks with multi-drug resistant organisms in the United States and also in Europe in various countries. But if we have a look in these different reports and outbreaks, we of course saw some damages on the endoscope, especially around the Albaran elevator. But there are also human factors which has to be taken into account. Again, the non-compliance with manufacturers' recommendations, but there were also missing reprocessing protocols. So how did the staff know what they have to do? This resulted into insufficient cleaning, drying, and storage of endoscopes, and also insufficient hand hygiene. So the reason is, why does it happen? Was there a lack of knowledge and experience? Was there a lack of awareness? Was a lot of time pressure on the staff, or even a lack of staff? And a nice review about 73 outbreaks showed that the problem is not only with duodenoscopes, it's also with gastroscopes and colonoscopes and all the other endoscopes. And the human errors were much higher in gastroscope reprocessing and colonoscope reprocessing than in duodenoscope reprocessing. In duodenoscope reprocessing, the combination of technical failures and human errors were more significant than in the others. So the human factor is really a key. But over the years, we can also see that the reprocessing is improving, and that are data from France, and they evaluated microbiological surveillance in the last 17 years. And you see here with gastroscopes and duodenoscopes and colonoscopes, the positive cultures decrease, while interestingly, the EOS scopes increase. So the positive culture with EOS scopes increase. You might say, okay, that is because the increased technical advanced procedures we do, but the reprocessing is still the same. So that shows we have also brings the emphasis to the EOS scopes, what we already did with the duodenoscopes. A survey from Offset from the United States shows that the automated system really improves the reprocessing. And when automated systems, manual clean plus washer disinfectors were used, the reprocessing was correct in 75%, while in manual reprocessing only 1.4% of the procedures were really correct. The staff reported, and that was 75% of the staff reported, that they really work under high time pressure, and therefore they canceled reprocessing step, and especially the brushing of the endoscope channels and the drying of endoscope channels, and that really then are the reasons why it came to infections or transmission. Another survey from an American conference showed that only 15% of the staff got a first induction training when they started to work with endoscope reprocessing. And only 25% of the technicians and 33% of the nurses had a formal training of endoscope reprocessing. Nevertheless, they thought, our knowledge and skills are fine, but in the final test, only 60% answered the questions correctly. And again, it was for instance, the air drying, so the drying of the endoscope, which were not answered correctly. So the attitude is really a point which has to be taken into account. And I like this graph because it shows our variety. Just explain it. The cows are our stuff, and you have people like me over 30 who come refreshed after the weekend to the endoscopy suite, and at the end of the week, this kind of stuff is tired. The younger generation has a big party during the weekend, come into the endoscopy unit on Monday morning and say, oh, I'm so tired. But during the week, they get more and more refreshed. The question is, at which time or which day do you want to have your endoscope reprocessed by which kind of stuff? So the behavior, the attitude of the staff is also a key issue in addition to the human errors. So the ESG and SGNA statement clearly shows that we need a sufficient number of staff with no competing responsibilities. This staff should have a formal training and with regular practice, and also refresher courses and regular updates are needed. It's also important to have regular audits and check the competencies from time to time and see if there are any refreshments needed. So when we have a look at the different countries, the formal training really varies greatly from just 1 hour to 120 hours. But there seems to be a common understanding among a number of countries saying, yes, we need around 3 to 5 days. And therefore, we took these 3 to 5 days and developed the European curriculum for endoscopy reprocessing. It is available on the SGNA website. And it's not only focused on endoscope reprocessing, it also covers occupational health and safety, ergonomics and PPI, the structure of the endoscopy and reprocessing unit, the structure and construction of the endoscope, and also validation, routine testing, and microbiological surveillance, and also basic hygiene. So all these things around are necessary really to ensure a safe reprocessing. And if we have trained staff like nurses or CSSD staff, we just need 3 to 5 days to update our knowledge and skills on hygiene and to get more input about endoscope reprocessing. But if we have non-qualified staff, and this kind of stuff is really increasing, then we need more time. And these people need at least 3 weeks training. So how can we implement these training structures? New staff need an induction program. And this has to include also a special module for endoscope reprocessing with a minimum, let's say, 4 weeks, around 100 reprocessing cycles they have to do when they start this training under supervision, and then they have a competency assessment. The new staff also need new instructions about the equipment available in the endoscopy unit and available in the CSSD department. And this special training is offered also by manufacturers, and it can be in-house or training or external workshops. But then really a formal training is needed. And again, it's 3 or 5 days for nurses and CSSD staff, and around 3 weeks for non-qualified staff. And it's a combination of theory and practice with a final exam and a competency assessment. And then in the endoscopy unit and in the reprocessing area, we have, as head nurses, we have to control our staff. So there needs to be internal audits to ensure the quality of the endoscope reprocessing, but also to identify possible mistakes, to recognize uncertainties and mistakes, and to identify additional training needs. And external audits are done by official bodies, and we have the JAC system in the UK, for instance. We have the ISO certification or other certifications. And in Germany, the official bodies also go to endoscopy units and check is the staff trained. And that is a requirement in Germany. And you see here data from 2015 to 2022 that with these audits, the number of training really increased. And in 2015, only 30% of the department said, yes, all my staff is trained, while in 2022, nearly 70% of the department say, yes, we trained all the staff. What about the new trend and developments? Does this decrease the need of training? No, but it will change the training. So we already spoke about the new developments, but also if we have robots in endoscopy, the training is still needed, but it will be a different training, even if we have a work release. And also with these single-use components, we need a training. Yes, they make our cleaning easier, but we have to be familiar with that. And even if we use single-use endoscopes, the reprocessing is not necessary, but I need to have hygiene-relevant handling during the procedure. So again, training is needed. So in conclusion, nosocomial infections can be caused by a combination of technical errors and human errors. And the human error can be influenced by structured training. And then we have knowledge and skills, but we also have a change attitude and awareness. And when we get new stuff, we need really a structured induction training program offered by the department and by manufacturers, and then followed by an official recognized course, a shorter one for nurses and CSSD staff, and a longer one for the unqualified staff. And we need regular updates and refresher courses from time to time, let's say 2 or 3 years. And the new developments that release our workload, that make our work easier, but nevertheless, training is necessary. Thank you very much.
Thank you very much, Ms. Beilenhoff, for that clear presentation. We already have a few questions coming through, and maybe to start with you, Professor Bruno. I think most people know that manual bedside cleaning, pre-cleaning are one of the most important steps in reprocessing. Why is there then still so little awareness on the efficacy of these steps? I don't get it.
Well, I think I doubt that most people are really aware of the importance of the manual pre-cleaning. I travel quite a lot, and I still see endoscopy procedures being done, scopes taken out of the patient, put in a bin, and it stays there for half an hour or 2 hours. And that's the ideal situation for biofilm to develop. And that's the biggest issue in endoscopy if we talk about this subject, the biofilm formation. So immediate rinsing of the scope and cleaning is the first pivotal essential step of the manual pre-cleaning, and in fact the whole cycle of cleaning.
But then why is this not being done then? And also, is it just lack of training, or? Well,
I think, yeah. Well, I think it's an important part of. To put it a little bit blunt, if you talk about the frequency of endoscopies, the work that is being done, the workload in endoscopy suite, that's a fast pace. Then the scope goes to the sterilization facility, where the least paid people of the hospital need to clean these devices. So it's about attention. How many physicians, endoscopists have truly visited the hygiene department and looked how these people clean these scopes? Not everybody has done that because they have other things to do. It's about awareness, and it's about also valuing each other's effort to help safety of patients and to clean these scopes.
Ms. Beilenhoff, what do you have to add to that? Because it's quite bizarre that we're still not doing this, right?
Yes, the first cleaning, I totally agree with Marco, is the first cleaning is really the most important step after finishing the endoscopy department. And it can easily be done also by the physicians themselves. So when the endoscope is taken out of the patient, even the endoscopist can rinse and flush the endoscope. The nurses often put themselves under a high time pressure. Yes, we have to finish the procedure. We have to change the room for the next patient. So yes, we work under high time pressure, but we also create ourselves a high time pressure. So we can bring more focus on these bedside cleaning, and we should do that.
So how are we going to solve that then, Ms. Beilenhoff? So if we don't spend, or we don't give enough time for cleaning, then it will never happen, right?
There is time for cleaning, and it's just a question of training and knowledge, and also the right attitude and awareness. We have to make that clear, what Marco said, what happens when we don't rinse and flush the endoscope immediately. Then we have residuals, then we have a biofilm, and this has to be transported, and this has to be taught to the staff.
Okay, Mr. Bruno.
Well, I also firmly believe that we as physicians have to give the example to our personnel. I talk to physicians that tell me that they don't have a problem with scope contamination. They never see an outbreak or a patient infection. Well, if that's the attitude, then nothing will change. You first have to recognize and acknowledge the problem in order to do something about it. So I think that's very important. We have to be aware as a team, and it's a team effort to try to contain this problem. And also it's about low-hanging fruit. It's the easiest thing we can do to try to decrease the contamination of endoscopes. So
yeah, well, at least we're talking about it now.
Yes.
And Ms. Beilenhoff, you were talking about training. and about the SGINA training program. So maybe you could tell us a little bit more about, you said some hospitals, do it better than others, but you said unqualified staff need 3 to 4 weeks of training. Is this realistic, and are hospitals really doing this? Because I understand labor costs are going up, there's only more and more time pressure. What are your thoughts?
But you get what Marco said, that is the lowest income people you get. You get a taxi driver, you get a technical staff, you get people who had no education, no hygiene relevant education. So you have to explain them how they do hand hygiene. They have to learn all the basic hygiene knowledge, skills, attitudes, what a nurse or CSSD staff already learned during their basic training. And this is what you have to teach these staff. And we established that kind of training in Germany. Yes, it happens. And the staff goes through a course for 3 weeks. It's in different blocks. And in the meanwhile, they work in between the blocks, they work in their hospitals, and they do that. And it is controlled by the regulatory bodies. And if you don't have this kind of training or provide this kind of training, then you get problems, and they can easily also close departments.
Okay, so in Germany, you've got it all figured out. Is that also the case in the Netherlands, Professor Bruno?
Well, I know it's in my hospital, we have these types of instructions, and that's organized. I'm not sure whether it's done on a national level, but I think given the importance of the subject, that's something that should be done.
Okay. One of the questions are already coming in here. Maybe for you, Professor Bruno, how to improve the follow-up of infections related to an endoscopic procedure?
Yeah, that's a key question.
Okay.
And that's also the reason why I say this is an undervalued subject. In my personal opinion, after doing research more than 15 years in this field, it's very difficult to trace these so-called scope infections. Again, with an MDRO infection, you probably will see a cluster of outbreaks, so multiple patients with the same bacteria. And if you have a very smart microbiologist and you are attentive yourself, you might be able to track that down. I had this issue in my hospital a few years ago. We had 30 patients, and it was incredibly difficult to do that and to trace that back, let alone for a sensitive microorganism. Now, in the past few months, we have been able to trace back for the first time in the literature a few infections with sensitive microorganisms caused by a scope. I'm very sure we see the tip of the iceberg, and it's a problem with certain scopes in a certain frequency, but everything we do about this should be evidence-based. We should seek the right science, and we need numbers with regards to incident prevalence of this problem.
So how are we going to improve it?
Well, I think we have to be, I like what is in the title, balanced.
Okay.
And we talk now a lot about green, which I fully agree is of essence. But as a doctor, I pledged an oath. It's also about the safety of my patients.
Yeah.
So there's a balance there. And we have to come up with the evidence where we have to use these, for example, single-use devices. I fully agree that to use them for every single patient is not a sensible thing to do. But I'm sure that there are certain patient categories that we can identify that have a certain risk that goes over a threshold of what we would find acceptable. And there you could think about, of course, patients that are very immune compromised, like liver transplant patients where we do complex procedures. But it also could be that you don't want patients to contaminate your scope with an MDO bacteria. Because if your reusable scope gets contaminated, that scope can infect other patients. So now we're doing an experiment in the Netherlands where we culture every patient that goes for ERCP to check whether that patient already is an MDRO carrier. Because nobody in the world knows what is the prevalence rate of MDRO carriership amongst patients undergoing endoscopy. It's a lack of science. We need more science to make evidence-based decisions.
Okay, well, we're glad that you're doing that. Ms. Beilenhoff, I mean, you're also involved with SGINA, so maybe you have also a European view on the training needs and how it's going. What are your thoughts in other markets and other countries? Are they all as good as Germany? And if not, what is the issue there? Is it money? Is it not industry paying for it? Or what is it?
In Germany, it's also not everything is gold, what is shining, we say. So we also have our problems, definitely. And but the system shows that with structured training, you can improve also the outcome. And therefore, I'm really a fan of the structured training program. And we can also increase their patient safety with it. And therefore, we want to bring it also to the European level. Often, people have no idea how to establish that. And therefore, SGENA provides a curriculum which gives a structure, and this can be implemented in the national systems. And that is a good way to do that. Yeah.
Okay.
And we also need microbiological surveillance to control really the quality of the reprocessing. Yes, we have infections, and we will not get rid of the infections because we can reduce perhaps the exogenous infections, but not the endogenous infections. So we will have patients having infections after endoscopy, but what Mark already said, we have to identify the bad boys. And this can also be done by training in combination with with quality control. And quality control means microbiological surveillance, but also auditing our stuff and to identify uncertainties and mistakes. It's a combination of everything.
Okay. Professor Bruno, who do you think should be responsible for training? Are that the manufacturers or the hospitals?
The responsibility for me lies with the hospital, because we are the end users and we are responsible for taking care of our patients. The help of the industry is highly appreciated.
But it's mandatory, isn't it? I think in the regulation now that industry has to do that.
Yeah.
But often hospitals find it too expensive or unnecessary and they don't do that, right?
True.
Okay. There are some questions for you here. So Professor Bruno, how often should we do culture tests for C and G scope per year?
That's a question that I cannot give a right answer. We do it once a month. And what that means is that potentially you have this kind of blindfolded time period of a month where if a scope was contaminated, you culture it positive, it could have infected the 30 days prior all the patients that were treated with that scope. Of course, if you do it each week, it's a week. Now, there are some centers in America where they even culture every scope after every procedure and only proceed with a new procedure after the scope is cultured negative. And then instead of 5 or 6 or 7 scopes, ERCP scopes, you need all of a sudden 21 or 25. So it's a balanced decision, and everything is balanced, what we are talking about on this table. But I think at this point in time, a month is a reasonable suggestion.
Okay. Also, one question for you here. Where would you prefer to use the Aqua Typhoon? In the endoscopy room or in the reprocessing unit?
Ideally, you would already rinse the scope in the endoscopy room, and that I would do just with rinsing water out of a basket, because having the Aqua Typhoon at the endoscopy suite is not sensible. It's not for the logistical reasons. It's not suitable, I guess. The most important thing is immediately transfer the scope to the disinfection area and immediately start the process with the Aqua Typhoon. I think that's the solution.
Okay. I'm also aware of the time. Ms. Beilenhoff, if you could just tell the audience that is listening and viewing us at this moment, what would you tell them that they should do that can really change the world within, of course, endoscopy?
The word of endoscope reprocessing or the word of endoscopy? If you want to change the word of endoscopy reprocessing, I would say teach your staff, have enough staff for endoscope reprocessing, and provide a good logistic. What Marco said to prevent delays and so on. So the combination of knowledge and experience, but also a good infrastructure and a good number of staff is needed. And then teamwork is a key in endoscopy. We have during the endoscopy, we have the endoscopist and the nurses and the dating person, and that is teamwork. And with that, it is with this teamwork, we will ensure patient safety.
Thank you. Professor Bruno, anything you would like to add?
No, I agree. And let's start with the low-hanging fruit. I think there's so much still to do with simple measures. Let's test these new devices that pretend to improve the adequacy of cleaning. And let's not make a scapegoat out of single-use endoscopy. Let's prove where it's usable and where it's of use and of safety of patients. So the right measure for the right patient.
Thank you very much, Professor Bruno. Thank you, Ms. Beilenhoff. And we'll take a 5-minute break before we come back to you with the last part of this event.